This case involves a 53-year-old female who presented with ongoing sleep disturbance, fatigue, anxiety, and intermittent vertigo. She reports frequent night waking, difficulty winding down in the evenings, and waking unrefreshed. During the initial consultation, she also disclosed that she has poorly controlled type 1 diabetes, which significantly changes the clinical picture and risk profile. She is perimenopausal, has a history of low iron, and experiences high occupational stress with early starts and long working hours. Her diet is relatively low in evening carbohydrates, and her family history is significant for type 2 diabetes and cardiovascular disease. So first, looking at predisposing factors, this client has several underlying vulnerabilities that increase her risk of ongoing symptoms. Long-standing type 1 diabetes places her at risk of glycemic variability, autonomic dysfunction, and micronutrient depletion, as well, which is all well documented in diabetes literature. Her family history of metabolic and cardiovascular disease also further increases her long-term risk profile. She is also perimenopausal, a stage associated with hormonal fluctuations that affect sleep regulation, thermoregulation, and GABA activity. A history of low iron and high occupational demands further predispose her to fatigue and nervous system strain. These symptoms are then maintained by several reinforcing factors. Ongoing glycemic variability and possible nocturnal hypoglycemia perpetuate sympathetic nervous system activation and sleep fragmentation. Poor sleep further worsens stress tolerance and glucose regulation, creating a self-perpetuating cycle. Sleep disruption itself worsens insulin sensitivity and stress regulation. Dehydration and electrolyte loss associated with hyperglycemia may contribute to fatigue and dizziness, while continued occupational stress limits recovery and nervous system regulation. There are then several factors which appear to be actively triggering or exacerbating her current symptoms. Poor glycemic control and nocturnal glucose fluctuations are likely contributing to night waking, anxiety, and fatigue. Nocturnal hypoglycemia is known to trigger counter-regulatory hormone release, including cortisol and adrenaline, which disrupts sleep. Chronic psychological stress and irregular work hours further activate the HPA axis, increasing evening cortisol and impairing sleep initiation. Dietary factors such as a low evening carbohydrate intake and caffeine use may increase the risk of nocturnal hypoglycemia. Hormonal fluctuations associated with perimenopause may also exacerbate sleep disruption and autonomic instability. This case contains some important red flags that require careful consideration. The most significant is poorly controlled type 1 diabetes, which increases the risk of hypoglycemia, hyperglycemia, and diabetic ketoacidosis. This necessitates ongoing medical oversight and co-management. Additionally, her family history of type 2 diabetes and cardiovascular disease increases her long-term metabolic and cardiovascular risk. So, based on the holistic assessment, several differential diagnoses are considered. These include type 1 diabetes itself, particularly nocturnal hypoglycemia and insulin dysregulation contributing to sleep disturbance. HPA axis dysregulation is likely present due to chronic stress and disrupted cortisol rhythms. Nocturnal hypoglycemia is a common but under-recognized contributor to sleep disturbance in type 1 diabetes. Perimenopausal sleep disturbance is also relevant, as fluctuating estrogen and progesterone affect thermoregulation and GABAergic activity. Iron deficiency may be contributing to fatigue, and early autonomic neuropathy is considered due to vertigo and the known association with diabetes. Given the complexity and risk profile of this case, further investigation is essential. HbA1c and continuous glucose monitoring are required to assess overall and overnight glycemic control. Fasting glucose and insulin provide additional insight into metabolic patterns. Iron studies, electrolytes, vitamin B12 and folate are indicated due to fatigue, sweating and diabetes-related losses. Thyroid testing is appropriate given fatigue and perimenopausal status, and postural blood pressure assessment is also important due to reported vertigo and the risk of autonomic dysfunction. The working diagnosis is HPA axis dysregulation and sleep disturbance secondary to poorly controlled type 1 diabetes, chronic occupational stress, and perimenopausal hormonal changes. This diagnosis reflects the interaction between metabolic instability, stress physiology, and hormonal transition rather than one single pathology. And now onto the ethical use of social media in naturopathic practice. So social media is increasingly used by health practitioners for networking, education, and professional visibility. While it offers valuable opportunities for health promotion, it also raises some important ethical considerations, particularly in relation to accuracy, professional boundaries, and client safety. So, Australian naturopathic associations, including Australian Natural Therapists Association and Naturopaths and Herbalists Association of Australia, emphasise that practitioners must provide accurate, evidence-based information, avoid misleading or exaggerated health claims, and protect client confidentiality at all times. These principles apply equally to online platforms as they do within the clinical setting. There are clear benefits to social media use when applied ethically. It can increase access to health education, support professional networking, and help normalise preventative healthcare approaches. It also allows practitioners to communicate their professional values and philosophy, which can help the public better understand naturopathic care. However, there are also significant risks. Social media platforms can facilitate the spread of misinformation, particularly when content is simplified for engagement. Boundaries may become blurred when practitioners interact publicly with clients, and comparison culture can promote unrealistic health expectations. There is also a risk of clients self-diagnosing or attempting to treat themselves based on generalized online information rather than individualized care. In my own practice, I would choose to use social media minimally and intentionally. I do not wish to rely on it as a primary means of building my clientele or professional reputation. Instead, client relationships would be developed predominantly through referrals, professional networks, word of mouth, and community notice boards, which align more closely with trust-based and relational care. This approach is guided by ethical considerations and personal professional values. Social media platforms often prioritize visibility and engagement, which can create pressure to oversimplify complex health information or present idealized outcomes that do not reflect real clinical practice. There is also a risk of promoting a one-size-fits-all view of health, which contradicts the naturopathic principle of individualized care. So for these reasons, I would use social media only as a supplementary educational tool, focusing on general wellness concepts, evidence-based health education, and professional reflection. Most importantly, I would avoid providing personalized advice, diagnosis, or treatment recommendations online. This is to ensure that clinical care remains within a formal consultation setting. So, by limiting reliance on social media and maintaining clear boundaries, I aim to protect client safety, uphold professional integrity, and ensure that naturopathic care remains ethical, individualized, and evidence-based. And these are my references.